Welcome to each of you. Thank you for joining us here today. Today, I'm very, very pleased to welcome Dr. Brian Barry to be with us. Dr. Barry will be speaking today about COVID-19, Canada, and theological ethics. Dr. Brian Barry is Professor of Religious Studies Emeritus at Notre of Maryland University, and he's also a professor here at the EI. He's been teaching at the Ecumenical Institute since 1998. And in 2008, he was named Dunning Permanent Distinguished Lecturer in Theology. A few years ago, Dr. Barry actually had to move, and so we lost him for a little bit as an EI professor, but he's been able to rejoin us now that we have access to Zoom technology and other things. So Dr. Barry is currently teaching MT600, our Fundamentals of Theological Ethics, for us this spring. And we're so excited to have him back as faculty. He received a master's degree in philosophy from Gonzaga University and a doctorate in theology from Boston College. His teaching and research interests include Christology and ethics, bioethics, and social ethics. And Dr. Barry is also a native of Canada and dual citizen of both Canada and the United States, and presently working on a monograph titled North American Theological Ethics, History, Approaches, and Issues. And Dr. Barry currently lives with his wife in Cleveland, Ohio. So we're so pleased to welcome Dr. Barry here today. And I will turn it over to him to share with us some insights on COVID-19 and the Canadian and US context.
Rebecca, thank you. Let me give a shout out, first of all, to Dean Brent Latham, who invited me, I think, last August to return to the EI and to teach via Zoom the course I'm presently teaching in Fundamentals of Theological Ethics. I'm very, very grateful to return to the EI, a place that for many years was a theological home for me, and I'm enjoying very much being in the classroom at a distance with my students this semester. So thank you, Dean Latham. I'm speaking from Cleveland, and yet I know very much the hallways and the faces of folks at the EI. So I have you very much in mind, and it's wonderful to look around the Hollywood Squares screen ahead of me and see so many familiar faces, particularly students from the past. So I'd like to talk about theological ethics in relationship to COVID-19 and the Canadian reality. I'm sure we're all fatigued by the reality that we're living today in the United States, but it is our reality. And I thought I would say something about the reality of the pandemic, but do so from a slightly different perspective, and that is from the perspective of our northern neighbor. I'm not a specialist in the Canadian reality, although I was born in Canada and lived there for 30 years. I have now lived for 30 years in the United States. Okay, so COVID-19, Canada, and theological ethics. Although next door neighbors on the North American continent, the United States and Canada have experienced significantly different death rates due to COVID-19. The United States, a country of 331 million people, has had 500,443 deaths related to COVID-19, amounting to 151 deaths per 100,000 people. Whereas Canada, a country of 38 million people, has had 21,720 deaths, amounting to 57 deaths per 100,000 people. In short, the number of COVID-19 related deaths per capita in Canada has been less than half that of the United States. Why has there been such a difference? While population density may be a factor, the primary reasons for Canada's lower death rate seem to be twofold: unified political leadership and a national healthcare system. So to speak about each of these in turn. Following the first confirmed case of the coronavirus in British Columbia, which is one of Canada's western provinces, in January 2020, Federal and provincial leaders across the political spectrum actively supported the mitigation measures proposed by public health authorities. When his wife, Sophie Gregoire, awaited her coronavirus test results last March, Liberal Prime Minister Justin Trudeau self-quarantined in his home for 14 days out of an abundance of caution, even though he was not exhibiting any symptoms. And when the Conservative Premier of Ontario, one of Canada's middle provinces, by the name of Doug Ford, was asked last April about a small anti-distancing protest in Toronto, he unequivocally condemned it. And Doug Ford styles himself as a kind of populist. Ford said, "It's reckless to do what they're doing, and personally, I think it's selfish," describing the protesters as, quote, "a bunch of yahoos." Not only has there been nonpartisan political leadership around the pandemic, but Canadians who have contracted the virus have benefited from their country's socialized healthcare system. Universal health insurance in Canada has meant that everyone can go to a doctor if they need a test or a treatment, and there have been fewer outbreaks of the virus among poor and marginalized communities, particularly Native people and migrant farm workers. Moreover, because provincial governments control the system of payment for healthcare services, rather than leaving decisions up to hospitals and insurance companies, public health authorities have had the power to essentially commandeer the healthcare system for national public health goals. In British Columbia, for example, the provincial government decided that in order to prepare for the pandemic, it needed to free up 30% of the province's hospital beds. So it instructed the public health authorities to make this happen. And because Canadian hospitals have fixed funding, the fact that some of these beds might have remained empty would have had no effect on the bottom line of these hospitals. While the number of COVID-19 related deaths per capita in Canada has been less than half that of the United States, Canada's response to the pandemic has been far from perfect. And I want to underscore this point. Most disturbing was the fact that as of June 2020, 81% of all COVID-19 related deaths in Canada had occurred in long-term care facilities, whereas in the United States, the number was only 31%. When this dire situation came to light last spring, Prime Minister Trudeau sent in more than 1,000 members of the Canadian Armed Forces to help care for seniors in 29 of the hardest hit nursing homes in Ontario and Quebec. The military was so appalled at the conditions in those homes that they sent a whistleblower report to the federal government. The Ontario report was particularly horrific, detailing cases in which residents hadn't been fed or bathed and were crying out for help. One resident was force-fed, choked, and then died. Cases of cockroach infestations, poor hygiene, and people being left on in their own feces for hours or days were also detailed. How had such horrid and inhumane conditions been allowed to fester? The main reason for Canada's relative failure in limiting the number of COVID-19 related deaths in its long-term care facilities is a crisis in its workforce. According to a report issued by the Royal Society of Canada called Restoring Trust, COVID-19 and the Future of Long-Term Care, the long-term care sector is chronically understaffed. Many employees, particularly care aides and personal support workers involved in direct care, are given variable and minimal formal training. receive the lowest wages in the healthcare sector, and earn a living by working part-time shifts at several facilities without sick pay, making them possible vectors of viral transmission. Studies show that they often have insufficient time to complete essential care and are at high risk for burnout and injury. Moreover, over the past 2 decades, the ratios of registered nurses to unregulated care aides in long-term care facilities have dropped steadily to contain costs, even as residents are living longer with diseases that require increasingly complex care, including dementia. To speak more theologically, Canadian religious leaders have not been silent in the face of COVID-19 and the deficiencies it has exposed in the long-term care sector. On March 30th, 2020, more than 80 religious leaders from across Canada issued a common message to all who call Canada home, inviting them to virtuous character and conduct in response to the pandemic. Entitled Hope, Gratitude, and Solidarity, this ecumenical and interfaith statement, which was initiated by the Canadian Conference of Catholic Bishops and the Canadian Rabbinic Caucus, with the support and coordination of the Canadian Council of Churches and the Canadian Interfaith Conversation, reflects a unity of thought and concern among Canada's diverse religious communities in the midst of fear and uncertainty brought about by the COVID-19 crisis. Important for our purposes today is the document's call to solidarity. Quote, "We urge all people in Canada to listen and follow attentively the directions of our public health officials and government leaders. We, as religious leaders, pledge to lead by example. We all must act together in confronting this virus. While everyone is vulnerable during this crisis, let us not forget those in our society who, prior to COVID-19, were already vulnerable to health and social ailments. As religious leaders, we raise our collective voices to highlight the necessity for greater attention to the needs of the homeless, the incarcerated, the elderly, and those already suffering from social isolation. This is a time for human solidarity. We all need to pull together. This is a time for us to draw closer to God." End of quote. A few months later, on July 1st, 2020, the Executive Committee of the Canadian Conference of Catholic Bishops issued a statement called "They Still Bring Forth Fruit in Old Age," quoting Psalm 92, verse 14, a lesson on caring in the midst of the COVID-19 pandemic. Highlighting the plight of the elderly in long-term care facilities during a time of pandemic, the bishops remind Roman Catholics and all people of goodwill that commitment to the common good requires caring for the elderly and the sick and advocating on their behalf for their dignity as persons. The COVID-19 pandemic, the bishops observe, has prompted a renewed discussion about important changes needed in order to address both the present and future challenges facing our elderly, who are already frail and compromised by the conditions in which they are forced to live. Our hope is that Canadians will gain greater awareness as to how our culture prioritizes the freedom, desires, and choice of individuals, and regrettably also tends to neglect the rights and responsibilities that promote the common good of society and the dignity of every person, including the elderly. This begins with respecting and protecting, in peace and justice, the fundamental and inalienable rights of each human person, as well as their authentic development and social well-being in the entire community. So, some possible ethical and practical implications that might follow based on these exhortations to greater solidarity and commitment to the common good made by Canada's religious leaders. First of all, efforts should be made to address the workforce crisis that leaves long-term care facilities understaffed and employees underpaid and overwhelmed. The Royal Society of Canada report, Restoring Trust, recommends that the federal government develop national standards for staffing and staffing mix and make provincial funding contingent upon meeting them. It should also ensure that data is collected on resident quality of life, care standards, and worker satisfaction, and which take account of disparities caused by race, ethnicity, gender identity, poverty, and other vulnerabilities. Further, provincial governments should immediately implement appropriate pay and benefits, including sick leave, for the large and critical unregulated workforce of direct care aides and personal support workers, and offer them ongoing training and mental health support. They also should make available full-time employment with benefits to all unregulated staff and evaluate the impact of one workplace policies, which are now in effect in many nursing homes that prevent employees from working at multiple locations. Secondly, and this is aspirational, long-term care facilities should be covered under the Canada Health Act, popularly known as Medicare. Former Executive Secretary of the Evangelical Lutheran Church in Canada and longtime public health activist David Frimmer has called the failure to include long-term care in the Canada Health Act Medicare's original sin. Passed in 1984, the Canada Health Act provided universal health coverage for all medically necessary procedures and codified the 5 guiding principles of the Canadian healthcare system: universality, accessibility, public administration, comprehensiveness, and portability. However, the bill at that time did not include long-term care, since in 1984, with the average age of death at 76 years, much of end-of-life nursing care was provided at home, or if necessary, in an extended care hospital setting. Today, while long-term medical services, including devices and nursing services, are largely covered through provincial health plans, long-term housing services such as board for nursing homes or assisted living facilities are generally left for patients to pay out of pocket. Although safety net programs exist in many of Canada's provinces, the quality of these safety nets is highly variable, and out-of-pocket caps in some provinces exceed 30,000 Canadian dollars per year, or 22,740 US dollars. While payment for long-term care remains a contentious political issue in Canada, a recent poll commissioned by Abacus Data indicates that 86% of Canadians support bringing long-term care under the Canada Health Act, with only 2% opposing the idea. Perhaps this public hope for such reform of Canada's healthcare system might well be one of the unexpected blessings to emerge from the global COVID-19 pandemic.
Thank you, Dr. Berry. We have a question already from Dr. Amy Richter, who has taught with us before. She's asking, she said, one of the things I'm hearing where I live in Newfoundland, Labrador, is that the spread of COVID and deplorable conditions were far worse in for-profit long-term care facilities in comparison with not-for-profit facilities. And she was asking whether you'd seen any data around this and what, what implication that might have.
Great question. In the province of Ontario, most long-term care facilities are private and for-profit, I think 51%. And there are others that are public and private and not-for-profit. I have read some analysis which suggests that the difference between not-for-profit and profit really has not been that significant in terms of the public health results. So when I was reading this data, I was wanting to see some indication that for-profit institutions ended up being more harmful for residents because profit was so central to these institutions. But there seems to be some data that says that's really not the key issue, whether an institution is for-profit or not-for-profit. Now, that could very well be different in the maritime provinces. I don't know.
Thanks. That's very helpful. As you were talking, a couple of things that occurred to me. First, I was just struck by how I think for both the US context and the Canadian context, this has been an opportunity to kind of shed a light on the healthcare system and to notice where there are some really big challenges, some glaring areas that we really need to be paying attention to. And I wonder if you would, if there are things in the United States context that you would notice in a similar way. Are there other things that you sort of notice coming to light from the US context as well?
Yeah. I mean, in using Canada in a way as a foil for reflecting upon our own reality, very early in my talk, I think I implicitly highlighted the fact that our country is very divided at this point in time, and that is reflected in our political realities. So for the past year, we certainly have suffered from a profound lack of unified political leadership around public health measures such as masking and social distancing and so on. And as a country, we have suffered greatly because of that. I think the light that has been cast on our healthcare system is that we have a patchwork system with many different components. Health insurance being tied for most people to employment, and then we have Medicare and Medicaid and the VA and so on. We don't have a coherent, unified public healthcare system, and consequently, a lot of people fall through the cracks because of that. I think we still have about 30 million people in the United States who don't have health insurance. So we have a long way to go. I think our present leadership in Washington, with its support for the Affordable Care Act and the possibility of a public option being available for people, something that people could buy into if they are under 65 years of age, I find very promising. As I reflect upon the US reality, I've been reading a book by Ezekiel Emanuel, and the title of the book, it's about a year old now, is called Who Has the Best Healthcare System in the World? And so the book begins by looking at the United States, and then it looks at Canada, and then it looks at many European countries and also some Asian countries, including China and including Taiwan. I'm not sure whether South Korea is part of the mix. In any event, Emmanuel makes the point that healthcare systems are path dependent. So we've set up a system in the United States that is very focused on private insurance. And we have a whole host of insurance companies and hundreds of thousands of people who work for these insurance companies. How difficult it is for us to change in any significant way that reality, because we've created a pathway over many decades. And so it's a bit like trying to turn the Titanic at this point in our history. So Emmanuel makes that point, and it's a very realistic point. It's a point, I suppose, that Reinhold Niebuhr would make about our reality in the United States. It's not all pretty, and there's a lot of socially embedded sinfulness in the system that we have created. But in another part of the book, Emmanuel says, if the United States one day transitioned from our existing private insurance system to a single payer system, like what exists in Canada, the US would be the first country in the world to make such a huge change. And I read that observation with a sense of hope about what is possible. That maybe we aren't condemned to living with what is, but maybe some real change in the future is possible. So this tension between Christian realism, if you will, and holding on to hope and a kind of Christian idealism, which I would suggest in our context has been inspired by the social gospel movement. It's been inspired by Black liberation theology and feminist theology, that hope for change is possible and that we carry that hope as Christians. So I'd recommend Emmanuel's book. It's an interesting global read on our North American reality.
Yeah, I think it's very helpful to see this sort of complex picture in thinking about the differences between the US and Canada, and then sort of as you're sort of alluding to here, sort of the larger differences kind of across healthcare systems. So it's easy, I think, in some of the discussion around healthcare for people to characterize one system or another as being negative or positive wholesale, and to be reminded there's a lot of nuance, right? So there's a lot to learn by studying one another's systems, and to sort of keep imagining together a better future for everyone, and you know what an even better system could look like. So I think that's a really helpful reminder that this is very nuanced and very complex. We have another question coming from one of our board members. He's asking, as hopeful as it sounds, practically speaking, how would you envision the transition from multi-payer to single payer occurring, given the divided political reality in the US?
Step by step, doing what is possible in small measure. I mean, I don't support in the US reality today the call for Medicare for all. I do not, because I don't think it's realistic. But it should remain, I think, for us, a goal that we incrementally move towards. In the Canadian reality, there was considerable opposition in the 1950s in the province of Saskatchewan against Medicare that was province-wide. And the obstruction came mainly from physicians who didn't want to lose control of healthcare and their financial interests. But people kept pushing, and Saskatchewan developed this Medicare system for all of its citizens. And then by 1966, this became a national reality in Canada with Medicare for all. So there will be forces of obstruction. There certainly are those forces in the United States today. And the best we can do, I think, is keep trying and keep pushing and trying to advance incrementally, aware that we disagree profoundly on what the common good might look like in the United States. I think some of us don't even think we should be talking about the common good, that really our country is about individual freedom and liberty, and that the common good is not something that we can really discuss or approach. And I disagree profoundly with that idea. We need to keep debating what our fundamental values are as a society, and what do we share beyond simply individual liberty.
Your comments sort of lead us right into a question from Dean Latham, who mentions that years ago a theologian noted a key difference between the US and Canada is that the common good is at the core of Canadian polity and individual rights at the core of the US polity. And he was wondering whether you concur with that assessment.
I do agree with that. I think in Canada, the common good tradition comes from many places. One place it comes from is the Roman Catholic Church in Canada, which for decades was located particularly in the province of Quebec, French Canada. Now, since the quiet revolution of the 1970s and the growing secularization of Quebec society, the Catholic Church has a different reality, a different presence in that province. But today we still have 39% of Canada's population identifying as Roman Catholic. And the common good tradition, the importance of the good of the entire community, which includes the good of every individual in the community, is an idea that profoundly shapes Canadian society. And I think some of the origins of that are from Roman Catholicism. More than that, Canada, as you know, has not only a strong French tradition, but a British tradition. And the British tradition in Canada is both on the right and on the left. So in other words, we have a strong conservative vision of society, where the common good would be understood in terms of family values and the importance of local communities and so on. But we also have a common tradition, which also comes from the United Kingdom, that is more on the left, a tradition of Fabian socialism, of the common good that includes protection of the rights of those who are poor and are marginalized. So for many decades in Canada, politics, political parties have been defined, I suppose, as centrist and on the right and also on the left. One of the things I say to my wife often is, what would the United States look like if we had more than two viable political parties? More options on the right, more options on the left. So Canada certainly has a strong communitarian tradition. I would say, however, that since the 1960s, there has been much greater emphasis on individual rights in the Canadian reality. And much of that is good. Some of that leads to distortions.
We're coming close to the end of our time, but I thought I might just ask about the statement that you raised, the ecumenical and interfaith statement, hope, solidarity, hope, gratitude, and solidarity, and just ask whether I'm not aware of anything parallel to that in the US context that was issued as a kind of statement. And I wonder, you might say a little bit about how, why that is, why Canada was able to sort of issue this statement and what kind of role you think that might have played.
Let me say, first of all, that I did look at some US statements, and the National Council of Churches issued an important statement last spring on COVID-19. I would say the American Catholic bishops, regrettably, have not spoken out about this reality as much as I would like. I haven't found any interfaith statements in the US context. So this Canadian statement, I think, is quite important, and I think probably reflects the multicultural, multi-religious reality that is Canada. Canada has become increasingly secular. There are many fewer people attending church than used to be the case 30 or 40 years ago compared to the US. The US looks like a much more religious society, and indeed it is, than Canadian society. But the growing secularization of Canadian society, I think, has opened up some new possibilities. One is acknowledgement of the interfaith reality in Canada, where many are still Christian, many have no religious identity. There is a strong proportion of the population that is Muslim, and indeed there's a strong Jewish presence as well. So there's an opening for interfaith collaboration in this more secular reality.
Yeah, thanks. As we begin to close, I'm going to invite Kay Gooduli to close us out, but I would also invite all of you who are here with us, if there are people that you want us to be praying for, to put the initials in the chat feature, and also to say a big thank you to Dr. Brian Berry. I think there are more questions coming in. This is one of those discussions that very clearly could go on for quite some time. So I really do want to thank you for sharing some thoughts and reflections and beginning some thinking and further reflection for each of us here today. So thank you.